Good morning, ladies and gentlemen. Our today topic is selective examination and therapy in dermatology. I want to focus on the most important examining methods and therapies because we have just limited time. There are more type of examinations, more type of therapies, but we will focus on the most important. So we will start with dermoscopy. Then I want to talk about punch biopsy, and then the rest will be physical therapies. You will see what I will select. So dermoscopy. It could look like this. It could look like this or this. You can even use your mobile phones right now because there are some handles. You can look like this. You can pretend that you're kissing somebody's hand or that you're a surgeon. Sometimes the former dermoscopes looked almost like CTs, but in general all these devices are the same. The principle of dermoscopy is that you're magnifying structures of the skin lesions that are not visible just with your eye. It's not only lens, it's not like augmentating lens. It's more sophisticated, it's more complicated. You have also polarizing lights, but this is what's going on, that you're trying to see some structures in the lesions deeper, more precisely, bigger. So let's start with some small quiz. I will show you several pictures of some skin lesions, and you will guess if they are benign or malignant. Unfortunately, you're not sitting here in front of me, so it's a little bit tricky, but guess at your home. So this is first lesion, and ask yourself if you think it's benign or malignant. Second example, what do you think? Another example. Another. What about this? And this. What do you think about this one? And this is last example. So now we will review all these lesions. So this is typical malignant, melanoma. This is really fine, it's seborrheic keratosis. Again, malignant melanoma. And again, benign seborrheic keratosis. This is very bad melanoma. In the opposite, even it's very dark, it's fine. Again, seborrheic keratosis. In the opposite, again, melanoma. I think this is very tricky for you, but it's really fine. It's completely benign. And this, I can't see you, but I think that most of you thought that this is malignant. Not. It's benign. Oh, last one. I forgot one last. And again, it's benign. So, I think that a lot of you know the rule A, B, C, D, E. Unfortunately, E is the most important from this rule, and although that sometimes it's just A, B, C, D. So I think it's something better than nothing. It's good to use this rule for likes, for not specialists. But as you saw on the pictures that I showed you before, it's not so specific because a lot of signs could be explained like that is the symmetry. For example, the last one wasn't symmetrical, but it's benign. From my point of view, in this rule, the most important is the evolvement, because the lesions are changing, have tendency to change, and it depends. If it's benign, then there is some type of involvement, or if is it malignant, then there is completely different type of involvement. But we have dermoscopes. So the most common dark lesion, black lesion on the skin is seborrheic keratosis, the benign one. But in this case, just with your eye, you can distinguish between seborrheic keratosis and something pigmented, possible melanoma. If you bend over, you're near to the lesion, I can still doubt. But this is when you use your dermoscopes. Then you see a deeper structure and you see some patterns. Everything is about structures, patterns. If is it symmetrical or asymmetrical. You needn't to know which patterns. But remember that this is what we are, what's the theory, what we are searching for. To show you even more sophisticated, here are some patterns, some structures, what we are looking for, and we want to see, we want to know if these patterns are symmetrical or not. This is melanoma, so all the patterns what we are looking for are asymmetrical. So I hope that you see my mouse. Here are some streaks. Normally the streaks should be symmetrical and regular all over the lesion. Sometimes the streaks are called network. But you see the network is just here, here. It's not symmetrical. Streaks also not symmetrical. The pigmentation it's normal, but should be homogeneous all over the lesion. The dots, the globules, again, normally the globules, if they are symmetrical, for example, at the border, no problem. But here, you can find them just here, so irregular dots. This structure, the blue whitish, well, this is very, very malignant sign. We hate blue color. Another example, but the principle is the same. You can see the network. The network, it's here, here, but here it's asymmetrical. Here is also asymmetrical. The structureless area could be fine, but it should be all over the lesion. Here it's just at some place. Peripheral dots, but just at this side of periphery. It's not here. the radial lines, radial streaking, just here. It's not here, it's not here, so irregular. In the opposite, seborrheic keratosis, this is the lesion that I told you that it's completely fine. Even it's very, very dark, you see that there are some structures like sausage-shaped streaks, and it's all over. Comedon-like openings, it's all over. So the structures are symmetrical. So even it's very, very dark, and I guess that just with eye you can't distinguish. You use dermoscope and you know that the patient is fine, there is no risk of melanoma. Another example when we can use dermoscopy, when dermoscopy is very useful, these findings, I think that all of you without any knowledge know that this is not okay. Even this, I think most of you guess that it's something strange, but this is a problem because benign nevi could be under the nail. And the problem is to distinguish benign nevi and melanoma. So again, you apply dermoscope, you put the dermoscope on the nail, and then you see, you can look at the streaks, if the streaks are really linear or if there are some gaps, if the streaks have same shape during in the nail, if there is some irregularity. And again, then this is different type of keratosis, and you see some different structures, and we know that these structures, that it's nothing pigmented, so if it's not pigmented, it's fine. We have a lot of books, we have servers, web pages where are tutors that can show you that you can distinguish between many diagnoses. But for us, the most important is to distinguish between something benign and malignant, especially melanoma, the squamous cell, and basal cell carcinoma. But I want also to show you that what's really new, what's trendy, is that you can use dermoscopy for some hair disorders, some hair diseases, especially for evaluating the efficacy of the treatment, because here it's obvious that the treatment works, but sometimes it's more complicated. You can use the dermoscopes even in cases where you can't do biopsy, or if the patient doesn't want to have biopsy, because there are also some specific structures and patterns. This is a really new finding. It's not even 20 years old when Polish guys and Italian guys found out this this new interesting finding, that there are some patterns, some specific patterns for some hair diseases. And right now there is a boom of computer digital dermoscopes it's connected with PC, with computer, and for example, this is very useful in some tricky cases when you want to evaluate the efficacy, because hair grow very slowly and the patients are of course nervous because of that, and they want to know if it working in few weeks. So in 8 weeks with your eye you really can't say if it improving or not. But the computer, if you apply the dermoscope to the same place, could tell you that here you can see that the computer is able to count number of hair in the states like anagen, catagen, and if you repeat that within few weeks, then the computer can count again and tell you if there is any change, some improvement or worsening or not. Another example of the evaluating of the hair disorder. So that was dermoscopy, and we move forward to punch biopsy. So in general, punch biopsy is very quick and easy way how to get a sample for histopathology, or in some cases how to make complete excision. What's very fine that it could be done even when the patient use some anticoagulating therapies. And up to 1 centimeter you needn't to do suture. So I think that you see that I am a big fan of punch biopsy, and why I'm focusing so much on punch biopsy is that it's not limited just for dermatologists. Punch biopsy could be done by all specialists, even general practitioner, if she has the equipment, could do that. And it's very easy, very quick, very sufficient. So I hope that at least some of you will become also fan of punch biopsy. So I have also some practical tips. So it's easy, it's fine, but before you start, ask the patient if there is some coagulation disorder or medication to be prepared for that. If the patient doesn't have any allergies to anesthetics, antiseptics, plasters and metals, because it's special type of scalpel knife, but still it's metal, so to avoid some allergic reaction. It's small procedure, but still it's bloody procedure, so ask about some transmissible diseases like hepatitis C or HIV. If you can choose a lesion, try the newest one, fresh lesion, not old. And again, sometimes you can't choose because there is just 1 or 2 lesions. But if you can choose, avoid areas we call V part. It's between shoulders and sternum and face. Also the distal part of the lower limbs, it's not perfect because there is quite often the vein insufficiency, and this could also make a little bit harder for the histopathologist to evaluate the lesion. And also it's not good to take a sample from traumatized or infected lesion. Yeah, we use anesthetics, but it's good if is it diagnostic biopsy, if is it not like complete excision, not to put anesthetics directly to the lesion but next to the lesion, because with the anesthesia you can make artificial edema, and then the histopathologist doesn't know if the edema is caused by the lesion or by the anesthesia. I recommend you to make a mark, the border of the lesion, before you start to put the anesthesia, the anesthetics, because if you make the edema, then the border of the lesion changes, and sometimes also the lesion blanches. And when you will get off the sample to your bottle, try to traumatize the sample as little as it possible. So don't squeeze it too much with your fingers or pincers. Also, normally we use formol or some different agent for conserving, but if we want to take sample for direct immunofluorescence, if you remember our last lecture, direct immunofluorescence, you're searching for antibodies inside the sample, then you need to squeeze the sample, not to put it in formol or another conservative agent. Also, if you want to take the sample for direct immunofluorescence, don't take it from the lesion, but choose perilesional area, so about 1 centimeter from the primer lesion. You need to freeze the sample for direct immunofluorescence, and for the transport instead of formaldehyde, use just some physiological saline. Sometimes if we need to make biopsy from child, and the child is really scared of injections, so from normal type of anesthesia we can try topical lidocaine, topical anesthesia, or sometimes even cryolization could make desensitization, and this could be used. So I hope that it will work, that I can quickly show you how easy it is.
A punch biopsy is most often used for deeper skin lesions. The area is first numbed with a local lidocaine anesthetic.
Yes, you see that
the area removed is about the size of a pencil eraser. The provider uses a skin punch tool to remove a small round piece of skin. It includes all or part of the lesion. At the end of the
and that's all. Yeah, I think this is not bigger than 1 centimeter, so the suture is, there is no need. If you want, you can do that. But you see, look, it wasn't exact time, but within 5 minutes you have biopsy sample. So that's, I think, perfect. You don't need to use operating room. You don't need to have nurses, any assistants. I think it's perfect. Talking about the direct immunofluorescence, this is how it looks. For example, this is something that is called net-like positivity. This is pemphigus vulgaris. Because the difference between pemphigus and pemphigoid, bullous pemphigoid, is that bullous pemphigoid have positivity, the antibodies binds to basement membrane. In pemphigus, antibodies binds to keratinocytes, the connection between keratinocytes, so it makes this appearance, and this is typical appearance for the bullous pemphigoid. There are some other techniques, and as we talked about the punch biopsy for histopathology, this is some interesting thing. I don't know how you're aware how the pathologists make the final decision. This is melanoma. Melanoma, I thought even a few years ago that it's easy diagnose. There is no problem for the histopathologist, but you can see that they need to combine a lot of different stainings. So melanoma, it's quite interesting, quite hard to make the final diagnosis. That's why we are so precise with the diagnostics. Melanoma is a very important topic, so there's another important single rule, because sometimes you see that there is Breslow and Clark staging. The best is to have both, but most important is the Breslow. Breslow is here. It's the depth. It's depth in millimeters. Clark tells you in which part of the skin the melanoma penetrates. But Breslow, according to the depth in millimeters, then you make the prognosis. Okay, and the second part of my topic, of my lecture, are the therapies, the most important therapies. You will have a special lecture for phototherapy and photodynamic therapy, because there are many aspects, but from the rest I will focus on cryotherapy, lymphatic drainage and lasers. But you see that there are more of the physical therapies. All these therapies were used right now. Diathermy or ultrasound therapy or iontophoresis, it's not so much used as before, or baxitherapy. So let's start with cryotherapy. In general, it's a therapeutic use of low temperature. Some division is according to strength, because we are mostly using that for cryodistraction, but you can also make cryodescalmation or cryostimulation. Everything is about the time. If you use just some short time, then you make only vasoconstriction, which is followed by vasodilatation. And if you make several cycles with this vasoconstriction, vasodilatation, vasoconstriction, vasodilatation, then you affect the metabolism in the lesion and around the structure, in the skin in general. If you apply longer time in the cycle, then usually you remove the horny layer. So you can also remove something which is on the corneal layer or inside the corneal layer. But mostly we are using much longer time, which doesn't make only vasoconstriction and vasodilatation, but we freeze the structure so much that we make that in the structure, in the cytoplasma, we make some crystals, and from the water some ice crystals, and these crystals destruct whole cell. So we make destruction of the cells of the lesions. Then there is some necrosis and apoptosis. The result is aimed destruction of the lesion that we want to remove. It's good for some benign lesions where complete excision should be too much, that the surgery there is no need to excise that. For example, some big seborrheic keratosis could be really inconvenient, but it's benign, so there is no need to make excision, and we can make just destruction. There are some different agents what we can use, but in most of the cases we are using liquid nitrogen. Problem with the liquid nitrogen is that it's very unstable solution. So you need these Devar vessels to keep the liquid nitrogen inside. It's very volatile. And you can apply the liquid nitrogen with this cotton balls, or I prefer to use this pistol, because when you open the bottle, the Devar vessel, then you lose the temperature and you lose also the volume of the liquid nitrogen. So if you put the cotton wool balls inside and then you take it out, you lose the temperature, the low temperature, which is essential. From this pistol you lose almost nothing. Okay, some just basics of phototherapy, because we will talk about it more in next lecture. There is some division according to wavelength. In the older times, most of the devices were UVA. The PUVA and TREPUVA, these are methods when you digest some photosensitizer, but during the time we found out that UVB, it's in most of the cases, not in all indications, but in most of the cases, like psoriasis, atopic dermatitis, more efficacious and more convenient, not so irritating. You even doesn't need to spend so much time in the cabin. So right now we are focusing more on UVB wavelength, UVB phototherapy. Another division of phototherapy is according to affected area, because we have some cabins where we irradiate whole body. But if you want to focus just, for example, on the soles or palms, there are some devices just for local irradiation. Then you can use higher intensity, because face is very sensitive, and in the opposite, for example, soles have thick horny layer, so there is with advantage when you use higher intensity, localized intensity, so you don't need to irradiate whole body with the face. Lymphatic drainage. I think that all of you have already read some articles about models that they are trying to avoid the cellulitis, not the infection, but the orange peel skin. But this made some mess. A lot of patients expect something different from lymphatic drainage because there is a manual and mechanical lymphatic drainage. For your skin, if you want to look younger, you can use just mechanical lymphatic drainage, but when we want to remove lymphatic edema, then we need to use both. Don't forget that there are some contraindications because you apply really high pressure, and this could be harmful for some patients that have disorders, especially regarding some heart diseases. Again, I will try to show you, give you some example. So we will start with manual lymphatic drainage. The manual lymphatic drainage prepares the lymphatic system for the mechanical. It's very important because you need to open the valves, the lymphatic valves, to be more efficacious and not dangerous. So, there are some methods regarding which region you want to affect. It looks almost like normal massage, but it's not. So you can see that there are some, it really looks like massage, commercial massage. But if I show you, so this was the region around the neck, but then you use a little bit different movements if you want to affect the higher part or a region around ears. So you see that you use some movements to open the valves to prepare the system. So different movements. And then after the manual lymphatic drainage comes the mechanical. And the mechanical is that you put something that looks like this. It differs if you want to remove some edema on upper limbs after, for example, some mastectomy where the patients have quite often the iatrogenic lymphatic edema, or if you want to affect lower limbs where there is typical lymph edema after some infections, typically erysipelas, the cellulitis, the streptococcal cellulitis, unfortunately in many cases harm the lymphatic veins in lower limbs, and then you're fine, the infection is over, but there is still the edema. So you put, this is the example, you put some sleeves of the device on the feet, and then you, I hope that you see my mouse, that you start, the machine starts to apply the pressure from here and up and up and up to higher etages. So that was lymphatic drainage, and the last method that I want to focus today are the lasers. So I think that most of you know that laser is abbreviation, so light amplification by stimulated emission of radiation. But I also think that not so many of you are aware how many lasers we are using, because for non-specialists, even for some other doctors, laser, it's laser, and most of the people think that with laser we are removing something ugly like skin tags or the nevi, but it's not so easy, not so simple, because there is a quite high number, almost 50% of lasers are non-invasive, so no cutting, no removing of anything. It's for some stimulation, so you can use some non-invasive lasers, for example, to affect face regarding acne, or you can use some lasers as analgesic method, because you want to affect the metabolism of the nerve endings. But then we have also a large group of invasive lasers. Sitting here, I would ask you, what do you think that, how is it working? But as you don't sit here, I can tell you that it's complicated, because the removing of something, it's complicated because there is not so many structures in the skin on which you can focus. Actually, there are three things. You can focus on hemoglobin, or melanin, or water inside the cell. So if you have some lesion, some vascular lesion, for example, spider nevi, which is the cosmetic inconvenient case, the small veins typically in face are dilated, chronically dilated, and you want to remove such a spider nevi, or you have some small varices on your feet, which is also vascular lesion, then you use some laser, which wavelength it's aiming on hemoglobin. You disrupt the hemoglobin in the erythrocytes, and with this you destroy the small veins. This is really aimed disruption, aimed destruction, and then you make apoptosis and the lesion is away. But if you have some benign pigmentic lesion, for example lentigo, which is from chronic sunbathing, chronic exposure of sunlight, then the pigment, it's different color, yellowish, brown, black, so you need different wavelength, and with this wavelength you play something like snooker with the deposits of melanin. you hit the melanin with the right wavelength, you disrupt this globule, this mass, and with the small pieces of the melanin are later also apoptosized. And if you want really to remove something like excision, like whole part of skin, like skin tag or something like that, then you aim for water, you make desiccation, and with this you are able to make something similar like normal surgical excision, but with no blood. It's perfect. It's also much more expensive, but this is a theory how you can use lasers. Okay, and with this I want to thank you for your attention. If you have any question, you have some time to type it now to the website, or you can type it later. I check if there is no question right now. No, it seems that there are no questions at the moment. So with this, I want to thank you again and see you at next lecture.